Case 2, high-risk left main in patient with depressed LV function utilizing IBP, Dr. Nimrak Kumar.
My case is he's a 31-year-old male, non-diabetic, non-hypertensive, chronic smoker, and presented with a severe chest pain of 5 hours duration, associated with sweating and some shortness of breath. And in ER, his pulse rate was 100 and the BP was around 70/50. And there is a bilateral collapse up to 25% of the lung fields. 2D echo shows akinetic LAD territory with severe LV systolic dysfunction. Ejection fraction is around 30%, and there is no mechanical complications. ECG is showing ST elevation in precordial leads and some elevation in showing in the AVR, ST depression in the inferior leads. In AR, loading dose of clopidogrel and Disprin was given, 5,000 intravenous bolus, heparin was given, inotrope, basically noradrenaline was started in ER, 80 milligram statin was given and shifted to the cath lab. First thing we have, because of the low blood pressure, large MI, and patient is on inotropic supports, we thought it's a high risk case, so we placed the IABP. And after that, this is the right shot. This was the picture after thrombosuction, repeated thrombosuction. We have done 3-4 passes. Blood pressure was little bit improved. Patient chest pain was still there, but it is improved. And what should we do the next? Because still the LAD TIMI1 flow is there, large thrombus burden. Already patient is loaded with the GP2B inhibitors. We have used the tarafiban, the patient is poor. So what should we do the next? So what we thought, because some studies has shown good result with the intracoronary thrombolytic therapy. So we have thought we should give the intracoronary tenecteplase. 20 milligram intracoronary tenecteplase was given. And this was the picture after 20 minutes of the tenecteplase. Some flow was, good flow was established, TIMI3 flow was established in LAD, SERC and RAMUS. Patient's chest pain is also reduced. This is the pictures taken after 30 minutes, almost 30 minutes we have observed him in the cath lab. And this was the picture. And this is the last final scene. At this moment, because the TIMI3 flow was established, there was no residual lesion. So stenting was deferred in this patient. We have kept in the close observation in ICCU. And post-procedure, inotropes was weaned off over a period of time. Patient was stabilized over the next 48 hours and the IBP was weaned off. This was the ECG after 48 hours. Patient was discharged after 5 days. And then again we planned the check angiogram, which was done 1 month, after 1 month. And I'll show the angiogram. And echo is showed 1 month after follow-up. LV function was improved from 30 to 55%. And this is the angiogram 1 month post procedures. So LAD ostial is showing some mild ostial, LAD has showing some mild ostial disease. Distal LMCA also, there is a mild eccentric plaque is there in the distal LMCA, and TIMI3 flow is there, and there is a no dissection or residual thrombus. So in the complex scenario like this, the management of thrombus burden is crucial. As we know, the primary angioplasty is basically a management of a thrombus, not balloon or stenting. And TIMI3 flow in the infarct-related artery should be the goal for successful outcome. And mechanical intervention like thrombosuction along with the intracoronary thrombolysis is a promising approach in a young patient with persistent large thrombus burden. As far as IBP concerned and other left ventricular assist device, already my previous speaker has spoken about this. But in the current practice, the IBP therapy is the easiest and most frequently used method for mechanical LV support in the cath lab. And it is continues to be a popular treatment strategy because it is most simple and safe employment, operation and theoretical advantages, particularly in the cardiogenic shock patient in which there are few other treatment options. If the patient is still on IBP and inotrope and goes into the refractory cardiogenic shock, then definitely the left ventricular assist device is a better option. Still the American College of Cardiology and American Heart Association has given a class 1B recommendation to the IABP as an adjunctive therapy to the revascularization STEMI cardiogenic shock, which is not quickly recovered by pharmacological therapy. Thank you.
In your cath lab discussion, since there was some irregularities in the proximal LCX and ostial region, did you consider any stent at that time?
Because this was a complex plaque, complex thrombus, which is involving all the three vessels, from distal LMCA to LAD to the ramus to the circ. And with thrombosuction, it was improved. But if putting it, because there is still the thrombus burden was high and there was only TB1 flow was there in the LAD. So that's why we thought even we put the stents, we can land into the problem. So some report, small studies are there. The small studies are there like Dr. Kelly's and other these things. They have shown a good result with the tenecteplase. So we have tried, we thought first we try with the tenecteplase and then see. And we are fortunate enough on that day and the patient also, the patient's flow was improved with the thrombolytic therapy.
You are lucky that patient
Yes.
responded to pharmacological.
Yeah,
You need something else. It's a young patient. So.
And meantime, the IBP also has given us some support
IBP
because initial blood pressure was 70 and with inotropic support it was around 90. So IBP was also given a support at that time. But once the flow has been established, blood pressure is improved by itself.
Yeah, here is predominantly a thrombus and less of stenotic lesion. Recovered with pharmacological therapy. So your myocardial function recovered. So you are lucky in that. Thank you.